Hello, this is the normal TE examination. In this talk, we will introduce the field of TE, highlight the applications, the procedure itself and its complications, and then also highlight material that's pertinent for your echo boards. And the field of TE really has its basis in the relationship between the esophagus and the heart. Because the esophagus lies directly behind the heart, the TE transducer inserted into the esophagus will be able to overcome the limitations of chest wall imaging. Soft tissue, rib spaces, air, that is really the goal of TE. And over the last several decades, TE has evolved in technology. What was once a fixed or rigid scope is now a flexible endoscope. What was once a monoplane or biplane transducer is now a multiplane transducer. And what this means is that a single crystal array is housed in the transducer, and this may be rotated in a 180-degree arc. There are images that can then be obtained all along these 180 degrees. And the modern day TE transducer has a distal end, which is anywhere from 9 to 12 millimeters. The controls are on the proximal end or the handle of the device. And the TE transducer is well demarcated with centimeter hashes, which basically give us an idea of a distance from the tip of the transducer to the incisors. General guidelines are 30 to 40 centimeters is the esophagus, 40 to 50 centimeters is the gastrum. And TE is extremely valuable. It has excellent image quality due to its proximity to the heart, particularly posterior structures. The frequency can often be increased as opposed to TTE. TE is very portable. You can do it in the ICU, the bedside, the operating room, the emergency room, and the resolution of structures can be anywhere from 1 to 2 millimeters. The disadvantage of TE is that it's an invasive procedure. There are risks of the TE procedure itself as well as the sedation required. It doesn't replace TTE, it's often complementary, and it's less helpful with anterior structures. So structures that are further away from the esophagus are harder to evaluate. And then finally with TE, you're limited by the constraints of the esophagus and the stomach, and physically what you can see from those two areas. This is from our ASE textbook, the 4 main indications for TEE. Evaluation of cardiac structures for which TTE is non-diagnostic or would be inadequate. TE has a long role in intraoperative guidance in the management of critically ill patients, and a newer role in the last decade in transcatheter procedure guidance. These are the key indications for TEE, and this is material that you can be tested upon on the echo boards. TEE is critical for valve anatomy, particularly mitral and prosthetic. It's the test of choice for left atrial appendage, anatomy and presence of thrombus. TEE can evaluate almost the entire aorta for aortic dissection and other acute aortic syndromes. You'll learn more about intraoperative guidance in other lectures. You'll learn more about TEE and its use in endocarditis in other lectures. And you'll learn more about transcatheter procedure guidance in the primary of interventional echo. These are the top TE indications at St. Luke's. The bulk of our TEs are done for valve disorders or atrial fibrillation. And then bacteremia, cardiac source of embolus is quite frequent. And finally, a small portion of TEs are also dedicated to structural cases. The appropriate use of TE is something that you can be tested on the boards. Particularly, they'd like you to know that TE is indicated in endocarditis suspicion when you have a moderate to high test pretest probability. It is indicated in acute aortic syndromes. And any time when you have non-diagnostic TTE images and TE findings might change clinical management. Equally as important as appropriate use of TE is inappropriate use of TE. So TE is not indicated if the TTE is non-diagnostic and the findings would not change management. It's not indicated in low probability endocarditis patients, and it is not indicated for the assessment of volume status in critically ill patients. These are the contraindications to TE divided into absolute and relative contraindications. There may be some questions on these on your echo boards. Primary contraindications relate to difficulty inserting a TE probe into the esophagus. And for many of these relative contraindications, I often find it helpful to find a GI friend and to really kind of work through the risks and benefits of doing TEs in patients with relative contraindications. Once we've decided to do a TE on a patient, we next move to how do we prepare. The patient preparation involves a fasting state, typically NPO for 6 hours. You want to rule out all contraindications of TE and resolve any relative contraindications. Peripheral IV access is required. And now in this day and age, pre-procedure COVID testing can be of value in certain institutions. You want to assess the oropharynx. So any denture should be removed. Any loose teeth should be documented and watched. And then you want to assess the patient for their overall sedation appropriateness for conscious sedation. The lab also has to be prepared for TE. So staff trained in moderate sedation and ACLS, these are the supplies you need, and this is the continuous monitoring that's required for oxygen saturation, heart rate, non-invasive blood pressure every 2 to 3 minutes. And end-tidal CO2, if available, can be quite helpful in alerting you to a decreased responsiveness or decreased breathing in a patient before the O2 sat fails. These are the bite blocks that we use here in Milwaukee to protect both the teeth of the patient and also our transducer. And these are the most common medications for sedation. So topical anesthesia with lidocaine or benzocaine products. Glycopyrrolate is used in some situations as a drying agent to minimize secretions. Sterile ultrasound gel, which facilitates ease of transducer insertion and also gives a little bit more acoustic interface for the transducer in the esophagus. And then sedation, which is typically a combination of a benzodiazepine and an opioid. Given together in small dose increments at appropriate intervals and titrated to sedation. Remember, the goal of TE is moderate sedation. So the patient should be sleepy, but responsive to verbal or tactile stimulation. While there may be oxygen that is required, really no intervention that is needed on the airway. The patient is still breathing on their own and their hemodynamics are usually stable. For situations where the patient is too deeply sedated, there are reversal agents for both opioids and benzodiazepines. Here are the starting doses and the titration. Methylhemoglobinemia toxicity is a rare complication of patients who get topical anesthesia with benzocaine products. The symptoms are very low O2 saturation and cyanosis. And it really occurs because benzocaine oxidizes Fe2, and when it is oxidized, iron can no longer carry oxygen in red blood cells. These are the treatments for it. It's important to recognize it if you're using what's sort of called hurricane spray or other benzocaine products. And equally important is to monitor the patient after the TEE. So it's a 2-hour observation period for moderate sedation. You generally maintain NPO status for an hour to let the topical anesthesia wear off. No driving for 24 hours. And before we release patients, all symptoms and potential complications are reviewed. And remember, TE can be performed throughout the hospital. So the same aspects of TE preparation in the echo lab are also in the ICU or the cath lab or the operating room. I typically use topical anesthesia on ventilated patients to make it more comfortable. And I titrate sedation depending on their existing sedation level. A jaw thrust can really help with esophageal intubation in patients in cath labs or operating rooms who are lying flat on their back and are often already endotracheally intubated. And this is a TE procedure. So the patient lies on the bed in their left side, a bite block has been introduced, and then the doctor places the TE probe into the mouth and down the esophagus. As you can see here, the esophagus and the heart are very, very close together. And so you get great views of heart structures. And then the TE probe can also be advanced into the stomach to get other views of cardiac structures. And these are the 5 main maneuvers that are performed in TEE. Angulation, rotation, tilt, position, and turning. And we'll talk about using these maneuvers as we go through TEE views in the next part of this talk. So when we rotate the transducer, we increase degrees, basically to rotate the plane at which the transducer is visualizing the heart. And you can see here that by rotating in different degrees, we can, for example, assess various parts of myocardial or mitral valve anatomy. And these are the recommended TE views, deep esophageal views only if required, but in general, upper esophageal views, mid esophageal views, the transgastric and deep transgastric views, and then prior to withdrawing the TE probe to evaluate extracardiac anatomy. This is your upper esophageal view. This is done in the upper esophagus, typically at 0 degrees, as soon as the TE probe is introduced. You can see in this the SVC, the pulmonary artery and its bifurcation, and the aorta. And this is a great view for understanding SVC anatomy, for ruling out sinus venosus atrial septal defects, and for looking at catheters or pacemakers in the superior vena cava. This is your standard esophageal 4-chamber view, the left atrium, the right atrium, the left ventricle, the right ventricle. And in this view, you can see that the TE transducer is very, very close to the left atrium and very, very close to the mitral valve. And one of the largest values of TE is its ability to understand mitral valve anatomy. So this is what mitral valve anatomy is. There are 2 leaflets, the larger being the anterior, the smaller the posterior. Both have 3 scallops that have a coaptation length and depth associated with them. And there's the anterolateral commissure and the posterior medial commissure. And to interrogate the mitral valve in 2D TEE, we would rotate the transducer array to get a mid-esophageal 4-chamber view, commissural view, 2-chamber view, and long axis view. And you can see here that at different degrees, you see different parts of the mitral valve and different parts of the leaflets. And you can expect some questions or some understanding of these views on your echo boards. This is a great way to look at the mitral valve, and you get a lot of information on mitral valve anatomy, leaflet anatomy. You have outstanding image resolution and can evaluate vegetations, clefts, other types of pathology. I find the true value of mitral valve visualization in TE to be in 3D. And we're going to talk a little bit about 3D in the next section. The stuff that we talk about related to 3D is going to be focused on the mitral valve, but is equally applicable to aortic valve, pulmonary valve, other cardiac structures. And so when we do a 3D TE, we first look at sort of that full volume. So this is a transducer here. This is the pyramid of information that the transducer is able to obtain in 3D. And 3D TE is really a balance between the spatial resolution or the scanning density and the amount of time it takes for a machine to process all of these lines, which is the temporal resolution. As you increase the spatial resolution, you tend to decrease the temporal resolution. Modern day machines have really improved upon this, but still in 2021, we're playing with these 2 as we try to understand a structure in 3D. And so the key is that 3D TE zoom, where you only use a portion of the full volume that has your region of interest. And what does that look like for the mitral valve? Well, here you see that in 2 planes, we have basically created a box around the mitral valve, ensuring that we have all parts of the mitral valve leaflets in both systole and diastole. From there, we get this wedge of 3D tissue, that small portion of the full volume that is our region of interest. How do we take this wedge of information and turn it into something meaningful? Well, the first thing we do is we bring this down, or basically we reorient this information to a view from the left atrium. And many TE software platforms will actually do this for you. You click on mitral valve and automatically it will create a view with the mitral valve view looking at it from on top of the left atrium. In this case, we did it manually. We brought the segment down to view it from the left atrium. And then once we have this, on this side of the screen is sort of that anatomic view of the mitral valve. We then rotate so that the aortic valve is at the 12 o'clock position, and this becomes the surgical view of the mitral valve. And this is really the standard 3D TE view upon which mitral valve pathology is evaluated. And you can expect to see 3D mitral valve TE questions on your echo boards. And now we see here a normal mitral valve in 3D TE. The aortic valve is on top. We see A1, A2, A3, P1, P2, P3. The left atrial appendage is not on the screen, but is on the left side. And you see the septum, and then you see also the tricuspid valve in the background. And this not only gives you an understanding of the mitral valve in its entirety, but it also gives you an understanding of the mitral valve in relationship to other cardiac structures. And from these views, you can then understand mitral valve pathology. So on 3D TE, this is a normal mitral valve. And then this is a slightly different mitral valve with a thickened and anterior leaflet and a very restricted and tethered posterior leaflet that doesn't really appear to move in 3D. And then using existing technology on many of these software platforms, we can actually rotate this 3D mitral valve. And we can see that this jet that is created from that restricted posterior leaflet is central and posteriorly directed. And then using the tissue transparency and other functions of the TE software platforms, we can actually eliminate the mitral valve altogether and just see the residual jet. And from that point, we can really do 3D quantification. And then this is another common mitral valve pathology. This is a large P2 flail. You can see the leaflet is flailing backwards, and there also is a ruptured cord. And then this is a normal bioprosthetic mitral valve in the center. The leaflets are opening normally in both systole and diastole. The prosthetic valve is sutured in to the mitral annulus. And this is in contrast to a different mitral valve pathology. So this is a patient with a large mitral valve vegetation on their anterior leaflet and a dehiscence of their prior prosthetic annuloplasty ring from this infection. And so not only do you see mitral valve pathology, you see relationship to other parts or other cardiac structures, but you can also see depth rendering, and you can see the prosthetic valve dehiscence from the mitral annulus. So 3D TE is very, very powerful in the mitral valve and other valves, but it also introduces its own type of artifacts. So here it looks like on this 3D TE of the mitral valve that there's a cleft in the anterior leaflet, and it really as a result of calcification or other structures that cause shadowing, there is this appearance of a hole or what we call dropout in some TE views. And the best way to resolve this is to use your color Doppler to basically allow you to differentiate what is truly a flow from what is dropout. Stitch artifacts are less common. In an attempt to increase the temporal resolution and spatial resolution of 3D TE, certain softwares would stitch together smaller volumes over different cardiac cycles. And as a result of the different beats, there was some translational motion of the heart, and various smaller volumes may not align. I will say that these stitch artifacts were very common maybe 10, 15 years ago, and have really gone away as technology has improved. In addition to the mitral valve, the aortic valve can be evaluated both in 2D and 3D. And here I just give you sort of the classic standard 2D views of the aortic valve in short axis and long axis. The coronary arteries can also be evaluated. Here are your still frames of the left main and the left circumflex, which can be seen very easily on TE. The right coronary artery can also be seen in both long axis views and short axis views in the esophagus. And then finally, the aorta can be very well seen on TE. And TE is a test of choice for ruling out aortic dissection. Most of the aorta can be seen. So here are views and angles for the aortic root all the way down to the thoracic aorta. The one caveat is that distal portion of the ascending aorta can sometimes not be seen. It can be obscured by that one area where the esophagus is close to the trachea. And that might be the sort of the blind spot or the one spot on TE where you cannot rule out an aortic dissection. But otherwise, aortic dissection can be very clearly seen on a TE. This is a 3-chamber view, short axis, showing the true lumen, the false lumen, and then this very, very mobile dissection flap. And on TE, your questions to answer are, where does this dissection start? Which coronary arteries, or are the coronary arteries involved? Is the aortic involved? Because that would change the type of surgery performed. Which is the true and false lumen? Are there fenestrations? Are the great vessels involved, which can sometimes be seen in these high esophageal views on TEE? And is there a pericardial effusion, which could be a sign of aortic rupture? So here you see that on this TEE view, the aortic valve is not involved. The right coronary artery can be seen very clearly here and is also not involved. And this dissection flap starts at the ST junction. And then here you see in this thoracic aorta view that you have a flap, which basically differentiates the true from the false lumen. And you see the false lumen is sort of slower flow here, but you can also appreciate these fenestrations, communications between the true and the false lumen. And TE can also evaluate for penetrating aortic ulcers, which can lead to intramural hematomas, as you see here in the thoracic aorta. And then TE can also evaluate aortic arch atheroma, particularly given the excellent image resolution in the thoracic aorta. And so you see here in this patient, some moderate atheroma in the distal thoracic aorta. And then you see here in this patient, a very large mobile atheroma, which puts this patient at risk for thromboembolic events. And then while we are still in the esophagus, we can also evaluate the integrity of the intratracheal septum. This is your classic bicable view, typically thought of as the SVC on one side, the IVC on the other side, with the intratracheal septum separating. Remember that the traditional bicable view really depends on how you're rotating or turning the probe. You can either be looking at the coronary sinus or the IVC, depending on which way you're turning the probe. So always good to keep in mind that they both are very close to each other in this bicable view. Otherwise, you see the left atrium, you see the right atrium, and you see the intraatrial septum where the ostium primum and the ostium secundum meet and oftentimes form a flap. In 25 to 30% of patients, this flap doesn't close and that forms the patent foraminal valley. The SVC here is also very close to the right upper pulmonary vein. And this area right here is where you could look for a sinus venosus ASD. And then you can also interrogate by agitated saline contrast the septum for right to left shunt. And here you see this patient with an intraatrial septal aneurysm that is provoked by asking them to cough during a TEE. Right atrial pressure is transiently increased and that intraatrial septal aneurysm pops over to the left side, opening up that patent foraminal valley and leading to a fairly significant right to left shunt. Remember, for intraatrial septal aneurysm studies or any studies with agitated saline contrast, it's typically a 7 to 10 beat capture to ensure that you rule out intrapulmonary shunts. And then here you see in 3D, a clot in transit through a patent foraminal valley. We saw a fair number of these in the last year with COVID and the sort of anti-inflammatory hyperthrombotic state that the COVID virus created. And this is a TE from a patient who did have COVID and who has this clot that is in between the patent foraminal valley. And then we'll next talk in the esophageal view about the left atrial appendage. So the left atrial appendage is an anterior and lateral structure. It's adjacent to the aortic valve. The best way to view it is actually to find the aortic valve, turn leftwards and anteflex, and you may also need to withdraw the probe slightly. What's important is that you have this sort of standard crescentic view of the left atrial appendage, but the LAA has multiple lobes. And in order to really interrogate all lobes to make sure that there is no LAA thrombus, you would need to evaluate it from 0 to 135 degrees. The LAA emptying velocity, which is a pulse Doppler taken at the ostium of the left atrial appendage, can also help you in evaluating for thrombus. Remember that many patients with non-valvular atrial fibrillation are at risk for LAA thrombus, and ruling out thrombus is an essential component of TE-guided cardioversions. So an LAA emptying velocity of more than 50 centimeters per second is considered normal, as you see on the left side of the screen. This patient is in normal sinus rhythm with normal velocities. On the right side of the screen, you see a patient with atrial fibrillation with heart rate in the 110s to 120s with very reduced left atrial emptying velocities of their appendage, less than 20 centimeters per second, which would put them at increased risk for stroke. And so here in this view, we see the normal left atrial appendage, one lobe of it. Our task in the next few cases is to differentiate thrombus versus spontaneous echo contrast, which is slow flow in the left atrial appendage, versus sludge, which is sometimes called early thrombus, versus an actual thrombus. And in this view, you see here a relatively well demarcated left atrial appendage with no thrombus. And in this view, taken of a patient with atrial fibrillation, you see something different. So you see slow or sluggish flow here, which is spontaneous echo contrast. Nothing is layering at the tip of the left atrial appendage, but this is clearly something that is associated with an increased risk of thromboembolism. One may still cardiovert with spontaneous echo contrast. The short-term risk of stroke is low, but the long-term risk of stroke is higher. And then here you see someone who has a clear left atrial appendage thrombus. You see this very large chronic appearing thrombus here at the tip of the left atrium on this 135-degree view. Really appears like it has been here for a while. And then you have this patient with rapid atrial fibrillation, and you see this layering here. And the question is this layering with some spontaneous echo contrast sludge, or is it a thrombus? And this is where I think contrast can be very, very helpful. Ultrasound enhancing agents can be done in TE. So most TE platforms will have an automatic setting for contrast, or you can do it manually by turning the power down. But what you see here with this left atrial appendage is that when we put contrast in, the contrast does not go all the way to the bottom of the tip of the appendage. And this blackness here really signifies that there's a thrombus present. And then finally in the esophagus, we can also look at pulmonary veins. The left upper pulmonary veins are often seen at 90 to 110 degrees. You turn leftwards in anteflex. Remember that the left upper pulmonary vein is adjacent to the left atrial appendage, and you can sometimes use that as a guide to then work your way through to evaluate them. The right pulmonary veins, you can see when you turn rightward 40 to 60 degrees. Remember the right upper pulmonary vein is adjacent to the SVC-RA junction, and you can sometimes use that as your guide to find the pulmonary veins. I also like to see the pulmonary veins in 3D. You can see very clearly in this still image, both the left upper and the left lower pulmonary veins as they enter the left atrium with the mitral valve at the sort of below at the depth of the screen. And then once we have interrogated all structures in the esophagus, we then move on to transgastric views. So the probe is then inserted into the stomach via the gastroesophageal junction. This can be a place where you can have resistance. And if there is a hiatal hernia, this can also be a place where you can have resistance. The transgastric short and long axis views are critical for LV function, mitral valve apparatus, and right ventricular function. I've left some degrees and some maneuvers on the slide for you to review. And then the deep transgastric view it occurs from advancing the transducer even deeper into the stomach. And with significant anteflexion, anywhere from 0 through to 120 degrees, you can really mimic the standard transthoracic apical views, the 3-chamber view, 4-chamber view, 5-chamber view. This is really the best views in TE for looking at the LVOT and aortic valve velocities. It's the spot where you can be most parallel to blood flow and get the highest velocities. It's a great view for tricuspid valve anatomy, particularly all 3 leaflets and short axis. And it can also be a good view for the LV apex, which is the furthest away from the esophagus, but is much closer to the stomach. TE Doppler assessment, just things to remember, the transducer is opposite of transthoracic echo, so it's not anterior on the chest wall, but it's in the esophagus. So everything is reversed. You can consider inverting the Doppler spectral display to basically mimic a transthoracic appearance. And it's very easy to align the mitral valve velocities parallel to blood flow, but it's more difficult to do with the aortic valve and other structures. The pitfalls of TE, so you can expect questions on separating normal TE anatomy from abnormal TE anatomy from artifacts. And remember, the esophagus and the stomach provide some anatomic constraints. We talked about the ascending aorta. We talked about aligning aortic and LVOT velocities, and air in the esophagus and the stomach can oftentimes limit image resolution. So these are just examples of normal structures in the right atrium. You have the crista terminalis here, which is kind of the SVC as it enters into the right atrium. And then just right adjacent to the crista terminalis is the right atrial appendage. So crista terminalis here, right atrial appendage here. You can see a eustachian valve here, which can be very prominent and often mistaken for a foreign body. And then you see here this very normal structure here, which is a catheter in the right atrium, which can often be mistaken. Catheters, pacemaker leads in the right atrium are very common. Good to know before you start a TE what the patient has in their right atrium. And then thrombi, vegetations, echo densities can be seen on these. And so these should also be interrogated in their entirety. The left atrial appendage has a whole other set of sort of normal structures. So you can see the circumflex artery right here. You can see the pulmonary vein right here. And then this very bright structure, which is called the Coumadin ridge or the Q-tip. It's a normal infolding of the pulmonary vein in the left atrial appendage. Can cause a significant amount of reverberation or shadowing or artifact. And sometimes contrast is needed to resolve whether there really is a thrombus in the left atrial appendage. This is a very normal structure and does sometimes appear on echo boards. And then just sort of a word about nasogastric tubes. So this is a patient I did recently. I put down the TE transducer. This is the image I got. And after removing the OG tube, this is the image I got. OG tubes, nasogastric tubes, can definitely interfere with contact and can lead to its own type of artifacts. And so it really depends on a risk-benefit scenario, whether to remove them or keep them in place and remove if needed. I'm going to conclude with the complications of TE. So the complications of TE are divided into two things: the complications of sedation and the complications of the TE procedure. Hypotension, hypoxia, decreased responsiveness, methahemoglobinemia are complications of the sedation part of the procedure. TE procedure, thermal injury is less common in modern day transducers, but keep an eye on the temperature on a TE probe. And in longer cases, structural cases in the operating room, pausing or stopping ultrasound energy when you're not using the TE probe can reduce the overall thermal injury to the esophagus. Trauma is also a rare but can be serious complication of TE. These are the numbers for the risks and complications of TE taken from our ASE textbook. And these are some nice images of basically complications. So they're the complications of TE insertion, the trauma, and the different positions where the probe can be mal-positioned that lead to complications. And then these are the multiple areas of trauma that can happen during the TE procedure: the oropharynx, the larynx, the esophagus, and the stomach. And all of these should be evaluated for before the patient leaves. Typically, blood on the probe signifies that there has been some trauma, and to the extent of it should be evaluated prior to the patient leaving. A few last words on the COVID-19 pandemic. I know we've all lived through it. TE is an aerosolizing procedure, as we all found out. And for TE, airborne precautions were what was recommended by the CDC. We did TE when it was appropriate, and we tried to avoid it when it was inappropriate. We performed TE with full PPE, including N95. Other institutions had used PAPR, and we tried to limit it as much as we could to essential personnel only. Pre-procedure COVID testing was done routinely in our lab, as it was in other hospitals, given the number of cases of COVID at the height of our surge, we didn't downgrade PPE if the pre-procedure COVID PCR was negative, recognizing sort of the high false negative of the test. We also switched to using these masks. There's a nice JACE paper about this from earlier this year. This is sort of a modified endoscope mask, and it allowed us to oxygenate the patient, but also limit the amount of aerosolization in a TEE procedure. A lot of the information that you saw is from our ASE textbook and also from the guidelines from performing TEE. This is a document from 2013 that has some great figures and other tables to increase your knowledge of TEE, both for doing TEEs and then also for the echo boards. In conclusion, TEE is generally a very safe procedure. It's really all about critical thinking, knowing the indication of the procedure. Unlike TTE, you don't have that ability to go back and take more images. And so you really need to have all the information that you need before you withdraw the TEE transducer. Definitely a learning curve with TEE. The more you do it, the more you build confidence. You can expect some TEE questions on echo boards about normal TEE anatomy from abnormal TEE anatomy from artifact. And then recognition of the TEE limitations is also something that's very, very testable. Thank you.